Good afternoon, everybody. I'll be talking about needle stick injury, which is a trauma to the healthcare worker. It poses a serious risk of transmission of HIV and hepatitis and is the second most common cause of occupational injury amongst the National Health Scheme. Ophthalmologists are more prone for these injuries. The aim of this study was to find the incidence of needle stick injury in the ophthalmologist and amongst various subspecialties, to study the economic burden, to study the effect of management strategies employed to improve the awareness. It's a retrospective interventional case study which was done for 7 years duration at Shankar Nethralaya. Standard sharp disposal protocols were followed as per NABH. All the new recruits, whether medical or paramedical, were oriented to sharp disposal protocols. They also got hepatitis vaccination. Sharp disposal bins were separately color-coded and were provided in the OPD and the wards. Regular presentations by the Hospital Infection Control Committee were given to discourage recapping of the needles. The instruments were supposed to be passed in the operation theater, the sharp instruments in a special tray. Special trolleys for sharp instruments in the operation theaters were adhered, and regular audits were done by the HIC to check on adherence of the protocols. Needle disposal was to be encouraged to be done immediately, and regular orientation programs were followed for the staff. A NSI form was also devised, and after every NSI, the wound was washed profusely with soap and water and cleaned with alcohol. A blood sample was collected from the healthcare worker and the patient, and sample was sent to the laboratory within 2 hours for testing of the HIV screening. And if found positive, antiretroviral therapy was started for 4 months following the NACO guidelines. The HIV 1 and 2 and then were repeated at 6 months. The hepatitis B and C testing was done on the 0 day, 3 months and 6 months. So we saw 159 needle stick injuries in 7 years, and maximum was in the fellow trainees, followed by the consultant ophthalmologist and the nursing staff, which was in sharp contrast to the study done by Gauri et al. And Elshiri et al., where the maximum NSI was seen in the nursing staff. Anterior segment surgeons were more prone, and we saw 79% needle stick injuries, and posterior segment surgeons, we saw a 21% needle stick injuries, but there is no published data to compare. This table shows the number of inpatients and outpatients and the needle stick injuries during the study period. And it suggests that every 12,500 patients we see, we are prone to a needle stick injury. Where it happened, the maximum in the operation theater, around 65%, followed by the laboratory and the ward. And this was in comparison to the published data. We saw maximum needle stick injury while passing the sharp instruments in the operation theater and while operating. In contrast to the published literature, we saw relatively less incidence of needle stick injury while discarding the needle or while recapping the needles, and this might be related to the regular education programs by the HIC. This table shows the number of anti-VEGF injections, but we found no NSI with the anti-VEGF injections. No seroconversion was noted, but there is a CDC study which shows that there is a possibility of 22 to 31% HBsAg seroconversion, a 0.5% HCV, and 0.3% HIV conversion. The cost is huge, and it costed us around 17,87,160 Indian national rupees for investigating these 159 needle stick injuries. It amounted to rupees 9180 per needle stick injury, and which is in contrast to 300 to 3,000 US dollars in US or 3,500 euros in UK for investigating a single case of needle stick injury. The HIC started regular video presentations to show the needle disposal and sharp disposal. Posters were posted in the wash areas, in the wards. Color-coded bins were provided, regular audits were done. This is one of the posters discouraging the recapping of the needle. And it helped. We reduced the rate from 25% to around 7 to 15% in the coming years. To conclude, needle stick injury is an occupational hazard which cannot be overlooked. Anterior segment surgeons are more prone. Anti-VEGF injections have not increased the risk. Economic burden is huge, seroconversion rates are low, but education can help us to reduce the incidence. Thank you.
I think it is a good study for the protection of your staff and other thing, but the cost looking to one patient, one person, 1 lakh rupees, a big one. And second thing, do you have any fixed posters for the guide of the other people who are thinking to protect their staff and themselves?
We try to devise these posters through the Hospital Infection Control Committee, and
But
we
you have
try
not
to
shown
post.
them.
No, that is the poster I
Only
showed.
one poster you
yes,
showed.
yes. But we take regular video presentations and classes,
Yeah.
and we are also doing auditing as part of our HIC surveillance for
Thank you.
adherence to the protocols.
Thank you. Any protocol by NABH or any guidelines that how much test to be done after doing a needle injury, or you have devised these protocols for yourself?
These are the standard guidelines by WHO, which say that you have to send the sample within 2 hours from both the healthcare worker and the patient, but you have to take a consent if patient agrees. And
Okay.
this has to be repeated. So we try to follow, the HIC tries to get the 3-month sample and 6-month sample as well.
That was not recommended by WHO.
Pardon?
That was recommended by WHO. That also 3 months and 6 months sample.
Yes, yes. We need to follow up these people that later are they, what is the amount of the antibodies these patients are having.
Okay. Thank you.
Thank you.